Our next speaker is Dr. Wallace. Dr. Wallace is a hematology oncology specialist at Optimum Medical Group, Inglewood, California, USA. Dr. Wallace, go ahead.
Hello, good evening. I'm going to talk about staging of colon cancer treatments and some risk factors. When somebody presents with symptoms of colon cancer, they would probably present to a primary physician, a primary hospital with some complaints. Their doctor, say for instance, doctors would have screened them either with a colonoscopy, the CT colonoscopy, and they would have identified a tumor. Then the doctor determines the stage. So the staging is done in collaboration with the gastroenterologist, the pathologist, the radiologist, and the oncologist, and of course the surgeon. So the colon cancer stage is typically based on the tumor node and metastasis staging system. And this stage represents the extent that the cancer would have spread. If you look at a cross-section of what looks like the intestine, you will see the stage 0 right there. And this is when during colonoscopy, a polyp is found, and naturally the polyp will be removed by polypectomy, and they may discover a little bit of cancer or early cancer formation inside the polyp. So that's the stage 0. And that's the stage that we want to find colon cancer. And that's the stage at which, if you do your colon cancer screening, about 60% of advanced colon cancer can be prevented. Stage 1 is the next stage where the cancer cells is now forming. You see it's beginning to go into the depth of the muscle of the colon, the wall of the colon. So this is usually less than 2 centimeters, 2 millimeters. It's usually less than that. And this can be cured by surgery. And again, most of the time, this is discovered also by screening. And once they get cured by surgery, you have a 90% survival, thereabouts. When you go to stage 2, you will see that the tumor is now really getting big. It's changing shape. It's gone deeper into the muscle, into the layer of the colon wall, and it's almost coming out into the other side of the colon wall, called the serosa. And you could have some cancer cells spreading either through the lymphatics, the green line, through the veins, the green line, the red line through the arteries, and or through the lymphatic channels, as the arrows are pointing. Usually these are microscopic spread in stage 2. As you move to stage 3, if you look at those lymph channels there, up there, you will find that if you move your cursor up a bit right there, you will find that now you're having more cancer cells in those lymph channels. If you compare in those lymph nodes, if you compare them with stage 0 and stage 1, even stage 2, that there is hardly any. So that is when it becomes tricky. At this point, your chances of cure becomes lower. And this is a time when you would be requiring multimodality treatment involving the chemo, chemical, medical oncologist, surgeon, maybe even radiation to try to render the person and cure them and make them disease-free. There's some stage 3 that can be cured, and there's some stage 3 that's very difficult to cure. And then when you get to stage 4, the cancer is really big, it's dipping into the lumen. This is when you start having bleeding. You start getting obstructive symptoms, blockage, feeling that you're not emptying your bowel well, called tenesmus, because there's a big tumor in the lumen of the colon. you can see that this one actually lifts up the wall. It goes through the wall of all the layers of the muscle. It involves the circulation. It involves the lymph channels, and it could spread to other organs. So that is stage 4. It is at stage 4 that we don't get cure. It is at stage 4 that we try to prolong survival. It is at stage 4 that we try to improve performance status, depending on how the patient presents, either with obstruction, weight loss, a lot of things, pain. So it's at stage 4 that the treatment begins to be very difficult. Again, screening could get rid of it at stage 0, stage 1, even stage 2. Next slide, please. Now, under the microscope, the character of the cancer can be defined as either low grade or high grade, and sometimes intermediate grade. Cancer cells are assigned numbers 1 to 4 based on how much they look. So we have, based on this grade, we have it from G1 to G4. G4 is when the cell just have totally lost its structure. G1 is when most of the cells that you see under the microscope, the cancer cells looks close to similar. You see that some structure is maintained. And grade 4 means poorly differentiated, high grade. It's totally lost its structure, and it is severe malignant in terms of behavior under microscope. So the higher the grade, the more abnormal the cells look. Low-grade cancers tend to grow slower than high-grade cancers. And most of the time, they start as low-grade, except in bizarre cases where a very small polyp would just grow rapidly, be aggressive, high-grade, G4, rapidly spread. And before you know it, the time of what we call tumorigenesis, which is from a normal cell to a malignant cell to a malignant metastatic to a high-grade malignant metastatic cell, could take such a very rapid time. And such high-grade cancers tend to be very resistant to therapy. They tend to recur very fast, and it's always a speed against time for the treating doctor and for the patient. So the life expectancy for people with low grade is better than not. So treatment. I kind of talked a little bit about the treatment as we were going over the stages, but let me recap. Surgery is often the only treatment needed for stage 0. And you could cure that 99% of cases, 5 years, 10 years, the patient maintains and still becomes cancer-free. Stage 1 surgery alone is also recommended. The technique could vary. For instance, stage 0, just removing the polyp could cure it. But now when they remove a polyp, the surgeons tend to, we'd like them to put what's called a dye to identify the site, so that if any surgeon needs to go back and just take a little bit more tissue to cut around the side, based on the nature of the polyp, they can do so because the person doing the colonoscopy has put a dye. It's called inking of the site so that we can find it later. Stage 2, surgery is recommended to remove cancerous sections of the colon and nearby lymph nodes. Chemotherapy is usually recommended in certain circumstances of stage 2, depending on whether they have nodes, depending on whether the tumor is grade 3 or 4 or low grade. So a low grade stage 2 that really is just a little bit big, does not involve lymph nodes. In an older person, we may not recommend chemotherapy. In a young person in their 40s, 50s, that we want them to have a survival of another 40, 50 years, we tend to give a little bit of chemotherapy, even though it's a stage 2. For stage 3, The treatment includes surgery to remove the tumor and lymph nodes, and usually followed by chemotherapy. If you remember, that's the tumor that's kind of a little bit big, trying to pop out of the lumen and also break out of the wall of the colon, may involve nodes and also local vessels and lymphs around its site. So the surgery usually involves taking as much lymph nodes and other things around there, omentum, peritoneum, around there, the surgeon decides. Most of the time, radiation therapy is not used in colon cancer for the colon itself, but it's used for other things, either to reduce pain, etc. I'll mention that later. Sometimes it is recommended, but in rectal cancer, which is the lower part of the colon, radiation is a very strong integral part of its treatment. Then for stage 4, treatment includes surgery, chemotherapy, radiation, either for pain relief or in rectal cancer or anal cancer, and in some instances, targeted therapy that we call immunotherapy. And these are based on molecular genetic markers on the surface of the tumor. If those are elaborated, if they're positive, then there is now targeted therapy that would be recommended to kind of form a lock and fit treatment to block what might be inducing tumor growth or what might be inducing aggressive behavior of the tumor. What the purpose of target therapy is to kind of downstage the tumor from being aggressive and make it less aggressive, prevent it from growing fast, and to kind of lock the key to tumorigenesis, tumor formation, and make the cancer undergo normal cell death, which is a process by which we repair our body and allow the patient to respond to treatment and maybe become cancer-free. Next slide, please. So how do we prevent colon cancer? Some we can do. I think the first doctor did tell us about prevention, what we could do with our diet, and also what are fixed causes and what are not. Important thing is to screen. So once you're over the age of 40 in some countries, or if you can afford it in any part of the world, you should screen yourself for colon cancer. At the age of 50, you get to have colonoscopy. In the US, you get your first one called the baseline. And then depending on what they find or do not find, they can tell you to come back in 5 or 10 years. In between, you can do those FIT tests that was talked about earlier. The goal is to find cancer early, remove that polyp that's about to form a cancer, and make yourself cancer-free. Be part of the 60% that can be cured or prevented from having invasive colon cancer by doing your screening. Maintain a healthy weight. It's easier said than done. Our diet in Africa is high in carbohydrates and red meat. We must cut that down. Eat more fruits and vegetables, maybe 2.5 grams or so. Eat fiber. We do have a lot of vegetables, green leafy vegetables, but I'm not sure if we have much more than that, but we need to put that in our diet. Our diet is actually quite rich. And if we look at our parents and grandparents that live close to nature and ate fresh food and fish, if you remember in those days, you don't get to eat too much red meat. It's just a small piece of meat. But now we get in the big pieces and lots of it during the day. That's not what it used to be. And they had less cancers. So maybe we need to reevaluate the pork, all those meats. Be active, walk, exercise. I know there's gym and various activities now. Even the Owambe involves getting dressed, taking all the steps, dancing, and all that. But then when we get out there and then you have more than your own allowed limits of alcohol, then you've pretty much removed the benefit of the little exercise. So I think men are allowed 2 drinks and women 1. If you want to limit alcohol, eat right, fruits, vegetables, don't overeat, avoid too much carbs. Now, mortality, that was talked about. I guess it's the 6th most common cause of cancer death in Africa. The disparity between sexes was not really elaborated, so I'm not really sure if that exists in Africa. Morbidity, of course, you will be sick if you do have colon cancer forming with abdominal pain, bloating, change in bowel habits, weight loss. This will affect quality of life. One needs to pay attention to that. Genetics. There are some familial kindreds or syndromes that makes one predisposed to cancers. Now, the familial kindreds, it's just a small percentage of the cancers of colon and most other cancers. But if you have it, then you're going to be at risk. But I think it's about 5% of the risk of colon cancer. It's all comers. So we have the polyposis syndrome, we have the adenomatous polyps, and a lot of a few others. This is not common in Africa, but there are some families that do have the familial polyposis syndrome, and those ones need to be recognized. And usually the treatment is pancolectomy at a very young age and early screening, sometimes in the teens, for family members. It is a very strong autosomal positive disease, which means that the penetrance is high. So the next steps, if you are 45 years or older, get tested. Do your fecal occult tests. Your friendly local hospital is there. Duchess has shown that they can do it, and some other hospitals in Lagos, I'm sure, and all over the country. And you can also get the kit, the fecal test kits available. Talk to your doctor about screening and the time that's best for you. Give them the family history. If you've had a 1st degree, 2nd degree, or 2 family members at below 60 that have had colon cancer, that puts you at a very strong risk. Thank you very much.